Okay, thank you, Marian. So, hi everyone, my name is Szymon Płotka and I'm PhD student at Sano Center for Computational Medicine, Informatics Institute at University of Amsterdam and Amsterdam University Medical Center. I'm supervised by Clarissa Sanchez, Ivana Iżgum, and Arkadiusz Sitek from Harvard Medical School. Today, I'm going to talk about deep learning for computer-assisted perinatal care, which is related to my PhD studies. Before the main presentation, I would like to thank all my mentors, clinical partners, and colleagues. So I want to show you how many people were involved to get and obtain my results. First of all, I'm going to talk about fetal birth weight prediction, but first I have to mention about fetal biometry, which is a gold standard ultrasound examination during pregnancy for fetal growth assessment and well-being. And the most essential parameters for fetal measurements are head circumference, biparietal diameter, abdominal circumference, and femur length. From these parameters, we can estimate fetal weight and gestational age in case if we don't have information about the last menstrual period. Fetal biometry has several challenges during routine examination. So first of all, fetal biometry requires expert knowledge by sonographer. And secondly, ultrasound image is a very noisy data due to a lot of artifacts and in this case by fetal movement. A low image quality can occur due to maternal characteristics like obesity or different race. And on these three images below, you can see a frozen frames to obtain proper fetal biometry measurement of fetal head, fetal abdomen, and femur. And this images comes from my own daughter. And now I'm going to talk about fetal birth weight, why it is important. So as I mentioned before, fetal biometry parameters are useful to estimate fetal weight. So let's focus on fetal birth weight, which is estimated in 24 hours prior to delivery. So it's a very important clinically indicator of newborn's growth, survival, and future health. So it enables to perinatal risk management and to determine the time of labor induction and the type of delivery, vaginal or cesarean. Macrosomia is when estimated fetal weight is greater than 4,000 grams and may cause infant and maternal morbidity, prolonged labor, and various delivery traumas, including shoulder dystocia for newborn, or maternal risk such as birth canal injuries. And in other side, we have low birth weight, is when estimate fetal weight is less than 2,500 grams and is one of the leading risk factor of neonatal death. But the most important is that the mean human error between the estimation and the real ground truth is 15% of the full body mass. So why artificial intelligence? How we can use AI to improve the performance of estimated fetal birth weight. So currently, the gold standard is a heuristic formula developed in 85 by Hadlock. And for this formula, we need 4 values of head circumference, abdominal circumference, biparietal diameter, and femur length. And they are dependent on sonographer's experience and, of course, examination environment. So currently, to estimate fetal birth weight, we use only numerical measurements. So the key is in image features. So on 3 short video sequence, I would like to show you how AI may be useful in automatic fetal biometry. So you can see identification and segmentation of fetal head, fetal abdomen, and femur length. So it works in real time, and this paper was published in this work was published in Physics in Medicine and Biology journal. And to develop and evaluate our methods, we use a multi-center, multimodal dataset that consists of fetal ultrasound video scans and tabular data. So the clinical dataset is supplied by 3 centers in Poland. So the first is from Medical University of Warsaw, second is from Poznań University of Medical Science, and third is from Center of Postgraduate Medical Education, which is just Bielański Hospital in Warsaw. And sonographers who performed the examination were instructed to record short video clips between 10 to 20 seconds, during which fetal head, abdomen, and femur standard planes were captured. So the frames below shows fetal head, abdomen, and femur. But images or videos obtained several hours before delivery are of lower quality than at earlier stage of pregnancy due to the lack of amniotic fluid. Our fetal weight prediction framework has potential to provide clinically relevant information. So during validation, the presented algorithm reduced expert clinicians, I mean about the second row, about our clinicians, by 30 grams and 1% of the full body mass. So in the first work, we didn't achieve this goal, but in our extension, we reduce this error. Moreover, we compare the impact of each fetal body part on fetal birth weight prediction. Supports the hypothesis that the best results are obtained using video recordings of the fetal head, abdomen, and femur, along with their corresponding clinical tabular data. However, the difference between fetal abdomen versus all body parts is relatively small. So you can see it's just 0.1 mean percent. So this demonstrates that fetal abdominal video scan alone may be sufficient to predict fetal birth weight within expert clinician error margins. So this is noteworthy because it implies that a simpler screening method may be utilized with equal effectiveness. So, but it is observed that the greatest error occurs when analyzing fetal head video scans, while the lowest error comes from abdominal. However, the proposed method, which utilizes all fetal body parts, is superior to all single part approaches. I presented our work entitled BabyNet Residual Transformer Module for Birth Weight Prediction on Fetal Ultrasound Video at MICAI 2022 conference in Singapore. This is a top-tier conference in medical image computing and computer-assisted intervention. We also submitted our conference extension to the IEEE Journal of Biomedical and Health Informatics, where our paper is currently in review process. And if you are interested in technical details, I would recommend to read our conference paper. Now I'm going to the next project. So in this work, we wanted to estimate fetal weight on various stages of pregnancy using only abdominal video scan. So we wanted to confirm our previous hypothesis that we are able to estimate fetal weight just using only one fetal body part, which is abdomen. So for this task, we hired 6 human readers to measure fetal biometry, full fetal biometry parameters on the set of 100 independent routine fetal ultrasound examinations at various stages of pregnancy, so between 16 to 40 weeks of gestation. So in this figure, you can see 4 scatter plots, which shows the standard deviation in millimeters of head circumference, parietal diameter, abdominal circumference, and femur length, and average estimate fetal weight by 6 human readers in grams. So you can see that there is a trend that if weight is greater, so also greater is a mean error. So then we compared our deep learning based predictions using a single fetal abdominal video scan and manually measured full biometry provided by 6 human readers. So here you can see a blunt Altman plot between each reader, and so it's reader 1, 2, 3, 4, 5, and 6. And as you can see, the results across all humans are similar, and we cannot see any trend. So we can say that our novel deep learning based method has the same error like humans. So we compared 6 human readers versus AI-based model. So we hired 3 experienced gynecologists, 2 residents in obstetrics and gynecology, and 1 experienced general radiologist. We calculate the mean absolute percentage error between each readers and deep learning. So the mean absolute percentage error is 3.75 for all readers. However, for experienced readers, we got error which is equal to that 59. And as you can see, that between experienced sonographers, R1, R2, R3, and R6, our deep learning based method achieve quite good results. And here you can see our residents. So we can say that our method is quite similar to experienced sonographer rather than residents. Now I'm going to talk on different project related to my PhD, which is Twin-to-Twin Transfusion Syndrome. So Twin-to-Twin Transfusion Syndrome is a rare but serious condition that affects approximately between 10 to 15 of monochronic twin pregnancies. And it occurs when there is imbalance in the blood flow between the twins, which can lead to serious complication and even death for both fetuses if left untreated. So the condition is caused by the presence of abnormal blood vessels connections in the placenta, called anastomosis, which connect the blood circulations of both twins. So these anastomosis are not present in normal monochronic twin pregnancies, but are almost present in TTTS. So the pathological blood flow imbalance results in one twin, the recipient. So here is a recipient who received too much blood, while the other twin is a donor, receives too little blood. So you can see on the left on ultrasound images, recipient and donor. And this TTTS is diagnosed in 14 weeks of gestation. What is a gold standard treatment for TTTS? So the gold standard treatment is fetoscopic laser photocoagulation. So it's a surgical procedure that is used to treat TTTS. The procedure involves the use of ultrasound guided insertion of a fetoscope in the amniotic sac, where the fetal surgeon identifies and ablates abnormal blood vessels of in the placenta using a laser. This procedure has been shown to achieve about 70% survival rate of both twins, and survival rate of at least one fetus in more than 90% of cases. And I can say that this is our own figure drawn by my sister-in-law. And the main challenges for TTTS surgery are turbid environment inside amniotic sac, limited field of view, and artifacts like laser pointer, amniotic sac particles, structural defects, or optical fiber artifacts. So to address these limitations, we implemented novel custom data augmentations to improve model generalization and avoid particular challenges in application to the TTTS segmentation in real time. So these challenges mostly correspond to artifacts such as laser pointer, amniotic sac, structural defects, and optical fiber artifact. So from the left, you can see input image, original artifact, and artificially generated artifact. Why AI? So accurately detecting and identifying placental vessels during TTTS surgery is essential for successful outcome and reducing the risk of surgical complications like TAPS or preterm birth. However, the visibility of the placental vessels can be hindered by the turbid environment inside the amniotic sac, making it difficult for the surgeon to target the abnormal blood vessels. And this can lead to a higher risk of surgical complications and poor outcomes. So therefore, the ability to detect and identify placental vessels in a precise way under different conditions, such as different lighting, angles, and level of turbidity, would increase the chances of success of the surgery. So this work aims to automatically identify and segment placental vessels during fetoscopic laser photocoagulation in order to improve visualization and ultimately the outcome. So now I can show you a short video sequence of my results in real-time placental vessel segmentation. So here you can see placental vessels, and the most important part is a very tiny placental vessel. So yeah, to develop and validate our solution, we used a multi-center dataset from 6 European fetal surgery centers. So the data from University College London Hospital and Genoa in Italy are publicly available. On this data, FETREC 2021 challenge during the MICAI 2021 conference was investigated, where my team won first place in registration task and third place in segmentation task. And the data from Warsaw, Madrid, and St. George Hospital in London is our in-house dataset to test our solution. So the data samples varies in terms of camera manufacturer, video quality, light, anterior or posterior placenta position, gestational age, and of course, surgeon's experience. In this figure, you can see our training and validation set that come from 2 medical centers. So Center A is London, University College London Hospital, and Center B is Genoa in Italy. And as you can see, video frames varies on image quality, light, and artifacts inside of the field of view. However, our test set consists the data from 6 centers. So we have a part of publicly available data set, which is A and B. C and D comes from Warsaw, A from Madrid, and F comes from St. George Hospital. So you can see a lot of differences, especially from St. George Hospital. The data from Warsaw, so D and E, C and D, are quite similar to the publicly available data, perhaps acquired with the same type of fetoscope. And this table lists the overall performance of semantic segmentation task on the test set across all centers. So the overall, our method achieved 75% in mean intersection over union metric. So it can be observed that TTTS net, which is our solution, achieves the best results with statistical significance, followed by UNet, TTTS net in smaller version, UNet++, and LMFF net, which is a base of our TTTS net network. Moreover, the segmentation performance of our method significantly outperforms the rest of the state-of-the-art methods for real-time segmentation. In this figure, we show an example of the qualitative comparison between the ground truth and segmentation output of placental vessel segmentation between TTTS-net and other state-of-the-art methods. The illustration shows that our method consistently provided accurate and robust segmentation, covering the entire map of the placental vessel, including challenging regions like reduced contrast, tiny vessels. So you can see a ground truth and our TTTS net, and our method is able to detect a very tiny vessel. So here you can see it. And for example, our method has a filed hose, but the other methods cannot do it. Limitation of our method. So our methods, our proposed method and approach has several limitations, which we plan to address it in our future work. So first of all, our framework is designed for the segmentation of placental vessels. So it will be nice and clinically beneficial to differentiate vessels into arteries and veins. But this is a very challenging task due to the high similarity between the two, and we plan to investigate this problem further. So we also didn't include the segmentation of different classes like fetus or tool, because we talked with our clinicians that it's not clinically important to do it in real-time segmentation during the TTTS surgery. So another limitation is that the proposed framework used only a single frame for segmentation. So while this approach is efficient, it does not take into account the temporal context of the video. So we plan to explore spatiotemporal feature representation learning in further work to avoid some fluctuations during the inference, and got more smoothly results. And of course, we want to add more data, as any deep learning project require a lot of various data. And lastly, our goal is to create a clinically usable system, and it should be evaluated using clinical measures such as improvement in fetoscopic laser photocoagulation success rate. And this will be an important aspect in future evaluation of our proposed framework. So thanks to our preliminary results, we got Clara DGX hardware grant from NVIDIA, to deploy real-time inference for computer-assisted fetoscopic surgery for TTTS. And we would like to test our solution in the clinical environment at the Bielański Hospital in Warsaw. And Bielański Hospital is currently leading European hospital in fetoscopic fetal surgeries like TTTS and spina bifida. In this project, we have an international collaboration with Dr. Robert Brawura-Biskupski-Samacha from Warsaw, who is the main clinical investigator, and Professor Asma Khalil from London. She is one of the best fetal surgeons in the world. And Dr. Jesus Rodriguez Calvo from Madrid in Spain. And to conclude, I presented my research work for my PhD thesis, including fetal biometry, fetal birth weight estimation, fetal weight estimation from only abdominal data, and computer-assisted tool for real-time placental vessel segmentation in fetoscopic laser photocoagulation for TTTS. And this research work resulted in 16 publications. So 20 of them are related to my PhD, and 4 publications are with different kinds of medical imaging domain. And at the end, I would like to thank for Foundation for Polish Science for funding my research work. Thank you.